Bismillahirrahmanirrahim. I am Dr. Atika Masood. This is the second part of the tumor lesions involving the liver and the biliary duct. We have done in our previous lectures about the classification of the liver tumors, and we have done the hepatocellular carcinoma. Today we are going to start with the bile duct carcinoma. Bile duct carcinoma has another name that is going to be termed as cholangiocarcinoma. It is very less common than the hepatocellular carcinoma, but more evenly distributed throughout the world. It is a disease of the older individuals, and males and females are equally affected. The most important thing that it is going to differentiate it from the hepatocellular carcinoma is that it is not associated with cirrhosis, while HCC, hepatocellular carcinoma, is associated with cirrhosis. And the most other important difference is that hepatocellular carcinoma is the common one, and it is endemic in the areas where hepatitis B and C infection is at risk. The highest risk is in Southeastern Asia, and the most important etiological factor that is involved in Southeastern Asia is the liver fluke infestation. So, if an MCQ comes to you that is asking you the most important cause of the cholangiocarcinoma, then it is liver fluke infestation. Then the other risk conditions include primary sclerosing cholangitis, congenital anomalies of the biliary trees like Colles disease or choledochal cyst, but most commonly the etiology is unknown. As far as its gross morphology is concerned, it is a firm white tumor. So here is another difference. It is firm, while hepatocellular carcinoma is a softer in consistency. So hepatocellular carcinoma is soft. This is whitish tumor. Cholangiocarcinoma is a whitish tumor, while hepatocellular carcinoma is a red tumor because of the increase in the vascular supply and the dilatation of the sinusoids. Then another important finding that is different from this tumor is in the hepatocellular carcinoma we have the plump hepatocytes, while in this we have an adenocarcinoma, and this adenocarcinoma is going to show you the mucin productions. It is going to spread to the regional lymph nodes, lungs, and to the peritoneum. It has extremely poor prognosis. We have seen in hepatocellular carcinoma, although hepatocellular carcinoma has a worse prognosis, but its variant that is going to be termed as fibrolamellar had a good prognosis. But if the patient is suffering from the cholangiocarcinoma, then it is having a poor prognosis. On a gross morphology, if you can see here, we can see that there are small nodules, because basically bile ducts are involved and these are spread throughout the liver. So it is the cholangiocarcinoma picture. Here you can see there is a glandular production, and if you can see clearly that these cells are the tumor cells which are forming the gland-like structures, and these glands are back to back and they are sharing their walls, they are coalescing together, and they are spread within the lumen. So here this whole area is showing you the cholangiocarcinoma. Then comes our new category, and this category is the angiosarcoma. As I have told you that angiosarcoma is the most important sarcoma that is going to happen in the liver, and it is very rare, but it is a commonest liver sarcoma, and it is more common in males than in the females. As From your previous knowledge, all of you must know that angiosarcoma, the main etiological agent is thorium dioxide or thorostress or vinyl chloride, PVC, polyvinyl chloride. All of you have been taught in your third year in the new plastic chapter that polyvinyl chloride is the most important carcinogen for the production of the angiosarcoma, arsenic, copper sulfate and other anabolic steroids. If you are concerned with the morphology, because all the vessels are going to be involved, then it is giving you a spongy hemorrhagic type of pictures, and we are having spongy hemorrhagic nodules throughout the liver. And basically what is going to happen in the microscopic appearance, that they are the malignant endothelial cells which are growing on the surface of the cell plates like a scaffold appearance or a tectorial growth pattern. So whenever we are talking about the angiosarcoma, it is growing like a plate-like pattern. So just remember this thing. These are having a scaffolding tectorial growth. It is going to spread to the regional lymph nodes, but as you know, it's a sarcoma, so mainly it is going to go via a blood route to the lungs, to the bones, to the adrenals and to the brain. So it has a high metastatic potential, and because of it, it has an extremely poor prognosis. If you are going to see here, you can appreciate that on this cross picture there is a hemorrhagic area and showing the necrosis, hemorrhage, reddish appearance on the cut surface of the liver. And if we can see here, you must appreciate, my dear students, that these are having the dilated vessels. And if you can see, I'm just pinpointing these cells, that these cells are not in the category of the hepatocellular because these are much elongated type of cells showing the mitosis, again a mitosis, rapidly dividing cells. We are not having any plump hepatocytes, we are having these endothelial cells. So these are basically endothelial cells. This is the appearance of the endothelial, long elongated tapering ends are showing the important characteristics of these endothelial cells. And if I am going to show you, these are your sinusoidal channels, and these are the red blood cells is very prominent, and these atypical cells are going to show you the hyperchromatic nuclei all over this area. So there is no, my dear students, just remember this, there is no gland formation, which is the important pathognomic feature of the cholangiocarcinoma. There is no plump hepatocyte here, and the only thing that we have here are our endothelial cells and the dilated vascular channels, and these are very atypical cells with hyperchromatic nuclei. Now our fourth most important category, and that are the metastatic tumors. As I have told you, it is the most common malignant liver tumors in the Western world, because in the cirrhosis, because of all the areas that are having any carcinoma can spread directly to the liver because of its rich blood supply. Then metastases are present in the liver at autopsy in 40% of all the patients with malignant neoplasm. That I have just told you that it's sometimes patient died of any tumor like lung tumor, and later on it was discovered that it has a metastatic nodule in the liver. The liver is the especially common site for secondary spread of the gastrointestinal tract tumors, pancreaticoid that I have just told you, lungs and the breast, and these are the most common sites. Nowadays in Pakistan we have seen in young women that breast carcinoma as it grows, and normally it can metastasize not only to the bones but also to the liver. If we are concerned with the morphology, Single to innumerable deposits can be seen, and large deposits can show you amplification, and this is very important sign of the metastatic tumor. If, my dear students, you are going to see this picture, you can see we have multiple nodules. These are showing some bigger nodules, we are having small nodules. So these are showing you the metastatic deposits all over the liver, and this process is called as amplification. So the metastatic carcinoma is the most important thing, and in the end we are having tumor-like lesions in which we have done focal nodular hyperplasia in our first lecture, nodular regenerative hyperplasia. There could be cysts like solid cysts, polycystic disease associated with the kidney polycystic disease, hydrated cysts, Gynococcus granulosus is causing the hydrated cell, or choledochal cyst, which could be a hereditary one or later on developing there. Then there could be a biliary hematoma in the von Meyenberg complex, or there could be any other lesion. So this is basically the end of the tumorous lesion. Today your homework or your assignment is to write down the differences between the cholangiocarcinoma and the hepatocellular carcinoma. You have to write down the differences in their gross morphology and in their microscopic morphology. So now the most important tumor that is happening in the kids is the hepatoblastoma. As its name indicates, that it has an important component that we can term as blast cells. So it is originating from the round blue tumors. We have already done a Wilms tumor in the kidney. We have done, you must be doing in bone and joints, a Wilms tumor. So these are all round blue cell tumors. If you can see this kid, its liver has enlarged in size and it has gone beyond the umbilicus region, and if we are going to see its gross appearance, there are no nodules here, there is no fibrotic nodules. It is just overall we are having an enlarged reddish soft enlargement of the liver. If you can see here, it's a very pathognomic picture of the hepatoblastoma, that there are multiple, on the gut surface there are multiple nodule or a band-like structure which we can see hemorrhage-like areas, grayish white nodules. So these are all surrounding the gut surface of the liver. If we are going to see this picture, you can well appreciate that there are no plump hepatocyte, but it has been replaced by these round blue cells, and these are much bigger than the lymphocytes, and this whole structure has been surrounded by these neoplastic round blue tumor cells, and in between these cells we are having some fibrotic areas, and in these fibrotic areas there are these round blue tumor cells. If we are going to see here again another picture showing you the similar type of morphology, these are your round blue tumor cells, and here you can appreciate it like in chronic inflammatory cellular infiltrate, they are lymphocytes, and here these are giving you the similar picture like lymphocytes, but these are much bigger in size, and they are constituting some glandular pattern, some trabecular formation, or going within the parenchyma in the similar pattern. So if we are talking about the hepatoblastoma, it exhibits two anatomic types. One is going to be the epithelial type, and second one is the mixed epithelial and the mesenchymal type. I just want to go in the back side, in which I have shown you that in the epithelial type it is going to form the glandular structure. Here there is a gland, here again there is a gland. If you can see here, it is spreading like a mesenchymal component. So it can have both of these components, or it can have just this simple epithelial component. So epithelial component is basically composed of the small polygonal fetal cells, and even smaller embryonal cells forming the acini, tubules, or the papillary structure that we have just seen. While the mixed type contains foci of the mesenchymal differentiation. So this mesenchymal differentiation is going to differentiate it from its epithelial type, and it can have primitive mesenchyme like neural tissue, it can have osteoid, it can have cartilage, it can have striated muscle. So anything can happen in the hepatoblastoma if it's a mixed type, because it is going to change into the mesenchymal cells. The frequent mutations that are going to be seen in a hepatoblastoma is WN2 beta-catenin pathway, and we have done in our neoplasia chapter that when there is a WN2 beta-catenin pathway, the cell signaling will be very high in this area, and cells are going rapidly into the transcription and translation phases and going rapidly into the cell cycle. So there will be the mutations are going on, and the most frequent mutation is FOXC1, which is a regulator of the TGF-beta pathway, and this is highly expressed in subsets of the hepatoblastoma. It is associated with familial adenomatous polyposis and Beckwith-Wittmann syndrome. You must have done in your GIT, in which Beckwith-Wittmann syndrome and familial adenomatous polyposis syndrome are associated with the adenomas in the GIT tract. So here is the end of the liver tumors. I'm going to repeat your homework for today, that you have to give me the differences between the hepatocellular carcinoma and the cholangiocarcinoma along with your attendance. Thank you very much for listening.